What's up, period party posse? I am so excited to have Esther Blum, an integrative dietitian and menopause expert and author of the brand new book, See You Later, Ovulator, on the show today. Don't you just love the name of that book? It kind of makes the post menstruation years sound not so terrible. Esther runs a successful private practice where she helps women through menopause with nutrition, hormones, and self advocacy, and she's been featured on Dr. Oz, The Today Show, and others. On this episode, we're talking about why women in this age group are so underserved and what we can actually do to thrive in this time of our lives. Esther is awesome and so vibrant, and I think you're going to love her as much as I do. Enjoy the episode. Hi, Esther. Welcome to the
Hey,
show.
hey Nicole, how you doing?
Hi, good. We were just talking before we started recording, everyone who's listening, that we actually met for the first time last night because we live close to each other. And it was such a treat because we're besties now.
We are besties and we love oysters and steak. And seriously, that's all I need. That's really all I need. And we both have like hysterical senses of humor. So that really was the icing on the cake.
I feel like that too. I know, right? I mean, you got 7 oysters though, and I got 5. But anyway, it's all good.
Don't hold it
I'm
against
kidding.
me.
I'm
It's all
kidding.
right.
I'll try not to. Anyway, I'm just kidding with everyone. Obviously, Esther was allowed to have 7 oysters. I told her to have the seventh one. um, oh my gosh. Anyways, I feel like there's so much to talk about. So, one of the things that I found out about you, first of all, last night is that your latest book, See You Later, Ovulator. How clever is that name, everybody? It's actually your 5th book. And I also found out that you're about to turn 52 years old, which basically blew my head off because honestly, I thought you were like 39 or something. So clearly, I feel like you're the person to be talking to about menopause and what to do, what to actually do that works.
I am. I'm actually 100, but all the supplements that I take make me look much younger.
All right, fair enough. I mean, whatever works, girl, whatever works. So, you said something else, or you said something in your book that I thought was fascinating, and I didn't know this stat. You said that by 2030, 1.2 billion women on the planet will be going through menopause. That is
Mhm.
a lot of people, a lot.
It's a lot of people. And you think about all the women who are currently in menopause who are criminally underserved in the process and medically gaslit and not getting nearly the attention and the care that they deserve, which is exactly why I wrote this book. I was on fuego
I
and
have no
not from
doubt.
hot flashes and not from hot flashes.
Honestly, I was actually going to say that when you chimed in and just said that, I was thinking at this time in the menstrual life cycle, it's so grossly misunderstood and women are, as you say, criminally underserved at this time, and it is so unfair because we're also criminally underserved at every other time in the life cycle as well, just so everyone knows. So this is just like the icing on the cake, I feel like. But in previous episodes I've talked about the physical and the hormonal changes occurring. So, I feel like we've really covered that. And I feel like people generally have an idea of what's occurring, but I feel like we could still maybe just talk a little bit about, what we're experiencing. What the heck is actually going on when we hit our 40s and then our mid 40s and then our late 40s and our 50s and beyond?
Yeah. Well, I'm going to talk about actually the life piece first, because that actually drives hormones. Stress is really driven from the top down. So most of us, by the time we're in our 40s, 50s, if we have kids, they're often teenagers at that time. Some people have toddlers, which is equally demanding. The toddlers is the janitorial duty phase. And then the teenager, it's like, you may as well be a potted plant, just kind of trying to listen and not overparent. But then like, your kids, it's just the wild west out there. And then we also, if we have the privilege of still having parents who are alive, they're aging. So and usually the 40s and 50s for women, spoiler alert, all of you out there, it's a time when like your career really skyrockets because you're well established, you're confident, you're feeling all the things. So that is when stress really takes hold and bottoms out your progesterone a lot. And as it is, so your ovaries, as I'm sure Nicole has so beautifully educated you all, your ovaries are the primary source of hormone production. while you are menstruating. And in your late 40s, that starts to drop off because your brain is stressed, number one, but your body's also saying, you know what, I really don't want to be carrying a baby or have the opportunity to carry a baby too much longer. So slowly, and as you go through menopause, especially, your hormone production from your ovaries peters out and really shifts to your adrenal glands. So what that means for you is that you start to notice all these physical symptoms. Number one is that your PMS gets increasingly more challenging, where you just have more intense fatigue. It lasts longer. It may have been like 5 to 7 days or, 2 to 3 days, and now it's stretching out. And you really notice the first half of your cycle is very different than the second half of your cycle. More irritable also, sore breasts, you may be getting some cramping or some spotting. And then when you do get your periods, they get a lot heavier because of that massive decrease in progesterone. You may not be estrogen dominant, but relative to progesterone, you would start to become estrogen dominant. And so your periods get heavier, get surges, you can start passing clots. That's a really good sign you're estrogen dominant. So things really begin to shift physically, and you'll notice PMS too. Your sleep is just not nearly as good.
Oh, the sleep. I swear. Yeah, that's been one of the things, as I was telling you last night, that's been such a problem. And, I was thinking about the fact that we start to go through all of these things. And for so many women who have not really paid a whole lot of attention to their menstrual cycle, throughout the previous decades, the 20s, 30s, and there's a lot of us, and I get it. I get that we're on a need to know basis with our hormones and our cycles for the most part, unless you have found me or Esther, and you're in the know. But what actually needs to happen for women when they go to the doctor to feel as though they're being heard? Because these things happen, and granted, in every other stage as well, we're kind of told, oh, well, that's just normal. It's a normal part of having a cycle, having a uterus, being someone who menstruates, whatever. And it's exhausting, right, to be told this, because you obviously know something's wrong. But yeah, in your experience, what actually needs to happen so women can go through menopause like a rock star?
Yeah. And by the way, common is not normal, and normal is not optimal. Okay. So you really need to optimize and not just be normal. And a doctor, a GYN, and my own was also, as much as I love her, was like, here's a prescription for the pill. No, thank you. Which is going to further continue to suppress your progesterone and make you feel worse. Number one.
Yeah.
Number two, synthetic progestins do not hit the same GABA and dopamine receptors in the brain that bioidentical progesterone do. So, Nicole, for my clients who are starting this, I give them a Dutch test. You can get a blood test, but blood tests don't always show the deeper picture. I use a Dutch test. It's the dried urine test for comprehensive hormones, because it looks at 21 of your metabolites, your estrogens, your progesterones, and your testosterones, and looks at how they're moving through your liver to see if you're detoxifying them well. Tells me a bit about your ovarian reserves, although really, an FSH and LH are much better indicators for that. But it also looks at your cortisol curve and the neurotransmitter production in your brain. So a lot of mental health changes also start during perimenopause, and especially menopause, because progesterone is kind of that chill out, relaxing hormone. And when that goes away, severe anxiety and or depression can develop, especially with lowering estrogen and testosterone too. So doctors will say, here's an antidepressant, right? And antidepressants can also quell hot flashes clinically, but they're never going to fix and support your adrenals, right? And they're not going to really get to the root cause of the problem, which is a deficiency in hormones, which can easily be replenished. So I love to test first and not guess. And, I love to get women on hormones as soon as possible, even when they're perimenopausal. And the North American Menopause Society has updated their position paper in 2022. This is hot off the press. saying, hey, you know what, hormones are really safe to use. They're fantastic in menopause, and for the long term, they're safe. So, I start using cyclic progesterone the second half of your cycle, so that number one, you want it to kind of mimic just your body's natural patterns. And number two, you can sleep the second half of your cycle, have less irritability, not be so depressed, and not gain all the weight and be bloated and feel just not like yourself. So I give it in a couple ways, actually. I love to use it topically for women who are early in their perimenopause, and this can be in the form of drops or a cream. Or for women who are kind of later in their perimenopause, we start them on a progesterone troche. This is an oral dissolvable tablet, dissolves under the tongue, and it bypasses your liver and the gut completely. So the absorption's quick, easy, and it gets those GABA receptors rocking and rolling.
And you feel like that just that has a profound effect on some of the more troublesome symptoms that pop up first?
It does. Like, I have a client who she's, an attorney in LA, corporate attorney, and was having periods so bad. And she has, we believe she has adenomyosis, although it's not been confirmed. But she was bleeding so heavily, she was pooling in her shoes. And this
Oh
was
my
with a
gosh.
tampon and a pad, right? So true hemorrhaging situations. I was just with my bestie. She's like, oh my God, I passed such bad clots before I went on progesterone. So both of these ladies went on progesterone second half of their cycle, and they're like, oh my God, I feel so much better, because estrogen left on its own. I mean, estrogen's like the tiger, right? And progesterone's like the nice kitty cat. So the kitten. So estrogen left on its own is freaking unhinged, right? And so when you oppose it with progesterone the way it's supposed to be, it calms things down. It controls the blood flow. It controls, the severe cramping and really those awful symptoms of just not feeling like yourself.
Oh my gosh, I could not agree more. I refer to estrogen in my book as the builder of the foundation of the house, and progesterone comes in and does the decorating. And I do feel I feel like it's so true. It's like, yes, we're just going to make everything pretty in here and slow your roll, Miss Foundation Builder. So yeah, I was thinking about the testing. So coming back to that, I had a guest on the podcast recently, and he was talking about testing as it relates to dispersing hormone replacement therapy, so prescribing that. And he's talking about testing being problematic during perimenopause because of the huge fluctuations in estrogen. So he tends to rely on symptoms more than anything. And I'd love your thoughts on that. I know you said, obviously, you love the test, don't guess approach to help establish a hormonal baseline. Do you feel like those two things are different, establishing the baseline and then testing as it relates to prescription of hormone replacement?
It's really interesting because estrogen levels do fluctuate up to 30% on any given day. Hello. So
Thanks.
that's like pretty insane. So yes, that's why I don't do as much blood testing with hormones until you're on them. And I rely more heavily on the Dutch. The Dutch, I'm really looking at how you're going to detox so that if you start, that you will do it safely, because hormones need to be like a gently moving stream. What you put in needs to come out through your poop every day. So if you're not pooping every day, or if your liver is not doing its job, then you're actually going to feel worse on your hormones. So it's no joke. It's not like these are, Skittles and you just kind of throw them all over the place and hope they land. You've really got to be taking exquisite care of your body throughout the process. And then I don't mind blood tests after the initial Dutch, or you can redo the Dutch to recheck, because once you get on the full scope of hormone replacement, once you're menopausal and you're on estrogen and or testosterone, then you do want to get your blood levels to a certain baseline just for bone density purposes, cardiovascular disease protection, all of those things. You really want to make sure, and that you can do simply with a blood test.
Yeah. Okay. So that's really helpful because you tend to hear a lot of different approaches and messages. I think, for women at all stages, again, And I feel like we talked about this last night, like people have found the solution for themselves. And so they push that out into the world as being the thing for everybody across the board. And I feel like that's so problematic because we're all searching for the solution. And if someone is so dogmatic about their view and their position on something, then you kind of tend to fall for that. And you're like, okay, let me try that. And then let me try this. And so I feel like a lot of the time women are just jumping from solution to solution.
That's right. And so the thing is with hormones, I've been researching and working with them for so many years. I mean, I've been practicing over 27 years. And so obviously I was treating people long before I started my own hormone replacement. And I'm full disclosure, I'm in perimenopause. I'm not full blown menopause, but, I really just saw it in my own patients first. And I was like, oh, thank God, this is available when I go through it. But I just saw the immediate relief. And these are doctors, these are people who've gone to the doctors and the doctors are like, hormones are dangerous and they're scary. And I'm like, dude, you need progesterone. You're not sleeping and or estrogen, right? Because progesterone helps you fall asleep, but estrogen really helps you stay asleep. And so we put them, I found them new prescribing doctors. Then they go back to the original doctor and the doctor's like, how can you do that? That's so dangerous. And they're like, hello, I wasn't sleeping. And then now I'm sleeping. Tell me what the problem is. And I put, by the way, Nicole, in See You Later, Ovulator, I put all these studies in there that are extremely supportive of the benefits of hormones and proof that they do not cause cancer.
Right. I know. I feel like in that last episode where I was talking to Dr. David Rosensweet about this exact thing, he did a whole monologue on debunking that. So it's so nice to just continue to hear that message because I feel like that message is sort of permeated through the decades and it's still a real problem. Like it really, that misinformation still lingers big time.
It does. And it's not being updated in pamphlets in doctors' waiting rooms. And doctors aren't updating themselves. So that's really because the doctors are on the front lines and treating us. And then we go to the doctor and people are intimidated by doctors and don't want to question them. So now they've got a book. They can literally say, the studies are all in this book. Read the studies. Imagine if every single woman did that, how we could totally shift the paradigm of hormone replenishment.
Oh, 100%. And, this brings me to this thought that I've had so many times, which is that this whole decade and beyond is not meant to be a nightmare. and how that is sort of the going narrative, right? That this menopause thing is just so confusing because first of all, there really isn't any good information out there. Like you were saying, right? They've only just updated the guidelines in 2022. You really have to dig to find people like you who are outside of the medical establishment or the mainstream establishment to truly get the right testing and the answers and the proper treatment, not just being put on an IUD or given the pill. And, this is crazy when I look at the evidence in your book from the stories that you share of these comments and these stories from women who are talking about what they've experienced. And I just, like I said, I feel as though I hear the same thing along the lines of these challenges that people meet when they're teenagers in their 20s and their 30s. So what do you think about that? Like the sort of rebranding of menopause, I suppose you could say.
Yeah. I mean, why not actually normalize optimization instead of normalizing suffering? Because
Yes. Say that again. It's so good. It's so true.
Why not normalize optimization instead of normalizing suffering? It is all our birthright to actually live as radiantly healthy humans. And as a healthcare practitioner, we have a responsibility to our own patients to do the work. I knew nothing about menopause when I first started, but guess what? The women who came to me were going through it. So I said, you know what? I'm going to spend, and I've spent years, researching and now looking at thousands of Dutch tests and thousands of stool tests and gut microbiome tests and really doing and reading clinical research studies and, listening to lectures and going to conferences. It is your responsibility. It is medically negligent for any practitioner to dismiss or to not refer them to someone who knows. say, you know what, this isn't my wheelhouse, but I have someone for you. So the other thing I do, and I'd love to do, is help my clients find practitioners and hook them up to doctors who I've personally vetted, because it's really important. But for those of you who are listening to this and saying, well, where do I start now? A great starting place is to go to ifm.org. It's the Institute for Functional Medicine.org. And you can call those doctors' offices and say, do you prescribe bioidentical hormones? Do you do Dutch tests? Do you do blood tests? How are you testing? And really interview them and ask your girlfriends, put posts on Facebook pages. Who do you know that's a good functional medicine GYN, which there are out there? I know because I refer people to them. Or, just a good functional medicine doctor who's really comfortable with hormones, because your GYN may be able to prescribe hormones, but may not understand the nuances of tweaking your dosage, because it's not always a perfect system out of the gate, right? People need to adjust dosages. I too needed to adjust my dosages. For whatever reason, 3 months seems to be the magic number where your body acclimates and is like, oh, right, okay, hormones good, I feel better. Not that you can't feel better sooner, but to really reach tissue saturation is at least 3 months. So, you need a doctor who's going to ride the waves, if you will, and be able to answer your questions and say, hey, you know what, Nicole, it looks like you're responding really well to the progesterone, but the estrogen needs some tweaking because your boobs are really sore. Let's figure that out. Or let's figure out how to end your hot flashes. Maybe we need to bump your estrogen up a little bit. Yeah. So that's really, that's how it's going to change, is when we demand it to change. Because do you remember, it wasn't that long ago when organic foods were not that widely available in our country. Now you can get them in Walmart. That is due to consumer demand. So when we demand it, that's how we shift.
Yes, love that so much. It's really about self-advocacy. And it's what I've talked about for years. You've talked about for years. You actually kind of have to get to know what's going on with your body a little bit so you can have these educated conversations with your doctor, or go find a doctor who is willing to listen when you realize that the doctor you have isn't, or is dismissing you, like you said. And what's crazy about what you said is that it's medical negligence, yet that is the story I hear across the board. That I told you last night, I had a teenager message me on Instagram, and she's 14 and has seen 3 different doctors about her excruciating period pain that is literally almost hospitalizing her every month because she's in such bad pain. And they've all sort of suggested endometriosis, but told her that she's too young for a diagnosis because it requires laparoscopic surgery. So she's reaching out to me on Instagram. Like, that's where we're at right now. And I think that is the most disheartening part of all of this.
Well, yes. And the reality is, Nicole, more than a lot of doctors. So, and here's the other piece, is that that's also criminally negligent. Doctors are going to want to put this 14-year-old on the pill. Yeah. Then after, if she has children, they're going to want to put her on an IUD.
Well, when we talk about like her even being able to get pregnant with advanced endometriosis by the time she's 30 years old or whatever, 15 years from now. So there's that piece too.
There's that criminal piece too. Yeah. But yet here's where it really grinds my gears, is that then when a woman's going through menopause, the doctor will say, oh, I'm not going to prescribe you hormones. Those are dangerous. I mean, seriously, WTF. I mean, seriously, right? And doctors have said, and my own PA said, before I worked with a functional doctor, I just, one of my good friends is a PA. I was like, can you just hook me up with some progesterone? She goes, I can't, because that's an off-label use. Well, guess what? Doctors prescribe birth control the entire month without taking that break for the withdrawal bleed, right? That's actually an off-label use. So why, there's so many things that are wrong with this. So once we call doctors out and say, look, I've done my research, I have the studies, put me on progesterone. That's how we change. And if they're like, no way, dude, well, that's cool, because there's medicine's a business like any other business. You could take your business elsewhere.
Exactly. Yes to that. So I've talked about this quite a few times on the podcast. And I actually mentioned this to you last night when we were chatting that, I'm 42 and even I didn't totally know what to expect when it came to being in my 40s. I was just like, oh yeah, we'll see how it goes. And I've spent so many years learning about women's health. So I understand completely when women say to me, they're completely caught off guard and they don't know what to do and they just feel like their body is failing them. And I was thinking about that, the weight gain, right? I've heard all about weight gain in perimenopause, and then in menopause, it's even worse. And I think I underestimated it. I didn't realize that I could put on weight so easily and it would be so hard to lose it just compared to a few years ago. I think back to 38, 39, it was very different. Do you feel like there's a general timeline when it comes to these sort of big milestone symptoms that you see in your practice? Or, in other words, like, can you expect those kinds of things to happen around this time, or does it just depend on so many different factors?
Yeah, it really depends. I mean, the state of your gut, the better your gut is functioning, the easier your transition into menopause will be.
Are you saying that my gut's messed up?
I don't know
I'm kidding.
because
I'm kidding.
I like to test and not guess, so I don't know. But
Oh gosh.
um but yes, so it really depends on gut health. It also depends on stress and stressors like caffeine and alcohol. Your body may not absorb, may not detox them as well. It also depends on, your cortisol levels and your sleep. And, listen, when your sleep is disrupted, I mean, all you need is 2 weeks of disrupted sleep to develop insulin resistance. So think about it. Like every period is basically, every period cycle is a time, the last 2 weeks are a time of insulin resistance, basically, because you're not
Yeah.
sleeping as well and your hormones are bottoming out, which changes how you metabolize insulin. And so the other piece is that with the decrease in estrogen and progesterone comes a rise in cortisol, and that's when you get the menopause. Not everyone has this rise in cortisol, by the way. Some people, it's really, you're so depleted, cortisol is really low. But either way, there's hope. Don't give up, because definitely I see women lose weight for sure in menopause. It's easier to lose weight in menopause when your hormones are not fluctuating all the time. That's when women do really well with intermittent fasting, and strength training combined really helps with fat loss. But the other thing you can do is make sure that you're lifting, which is something you're great at, Nicole. I mean, you said you lift 3-4 days a week.
Yeah. Yeah.
Yeah.
So obviously I put on weight and muscle, thank God. But it's just
God.
interesting that I feel like there's definitely an extra 10 pounds. I assume some of it's muscle, but I'm shocked because I've never weighed this much in my whole life. And so and I don't, then things are definitely tighter. There's no doubt about that. Dresses I've had from like 3-4 years ago, I'm like, whoa, okay, interesting. Again, some of it's muscle, I imagine, but it is just an interesting time. And it's just good to notice this stuff and to really, I think for me personally, I'm using it as a gauge for what I need to change. Like last night, just so everyone knows, I had a vodka gimlet and I was
Me
up at
too.
3 o'clock in the morning. Yes,
You
Esther
were?
did too. Yes, I got up at
did.
3 o'clock. Well, I woke up at 3 in the morning and I was like, come on. And cursed that little vodka gimlet for a second. And then I was like, well, I actually drank the thing. So it's not its fault. But it is crazy because that happened. And I was telling you that I have gotten my sleep really good to this point. But then, yeah, the one glass of alcohol will do it. And so
Yes.
I feel like there's this intolerance to all these things that we were pretty tolerant to in our 30s that just is, again, catches people off guard.
It does. And the
Yeah.
other thing you want to think about is you want to think about optimizing your protein intake during this time too, which is really, my goal for people is a gram per pound of their ideal body weight. So if you're 140, you eat 140 grams, 120, you eat 120 grams. But if you're not sure what that even is, or really hate math like me, just aim for 4 to 6 ounces of protein at your meals and snack on protein as well, because number one, protein is going to stabilize your insulin and blood sugar for up to 6 hours after you eat it. Number two, protein is the only nutrient that shuts off the hunger mechanism and signal in the brain. And number three, it really raises dopamine and serotonin and fights cravings. So you're much more in control of your eating. You're not snarfing down, sleeves of Oreos and snorting lines of chocolate chips off the counter. So, and it's really easy to overdo the sugars and carbs, but like no one binges out. I mean, we split a steak last night and couldn't even finish it. Your dog, how'd your dogs enjoy it? Were they
actually
like,
Hayden
so
had
happy?
it. He was like, oh, there's steak. I'm like, oh, I was going to give this little tiny treat to the dogs, but he was like, hell no.
Hell
So
no. That was
I know,
good
right?
steak.
They did not get it. They got
Okay.
another tiny little treat instead. But yes, it was great steak. So yes,
Yeah.
absolutely.
Yeah.
I agree with the protein thing. That has definitely been a game changer for me. And I see that with my clients as well, too. You know, I was thinking about this again, like my scenario. So someone in their early 40s, and we were talking about the symptoms that I experience, right? So the sleep issues kind of come up over the past 6 months. My period is definitely lighter. So that to me is interesting when I think about the conversation around perimenopause in general, like what you were saying, that you notice the periods that are a lot heavier and flooding and longer and then shorter cycles. So my cycle has pretty much stayed the same, but my period is definitely lighter. And so I think that's probably because estrogen is dropping for me. So do you feel like there are different sort of scenarios that show up in perimenopause where some people might have a lighter period and then it just all tapers off and then that's the end?
Yes, absolutely. I mean, you are case in point, right? Your progesterone is seemingly okay and your estrogen is low. So that can absolutely happen for sure.
Right.
And in that case, we really work to really support the ovaries and get those good cold water fatty fish and caviar and butter and liver, get the good fats going to really nourish those ovaries to sputter and keep pumping out estrogen as long as possible. But
I'm doing all the things.
Doing
yes,
all the
I'm like,
things,
come on,
right?
little ovaries.
Come on,
Keep
ovaries.
going.
Stop
I know, right?
overreacting.
Exactly. I mean, because when you think about it, like again, someone like me, I feel like me and all the women around my age, we're in the in between, right? Because coming back to this hormone replacement therapy and what we said last night, I was like, do I need hormone replacement therapy? How does it work for someone who's 42 or 43 and the ovulation is still happening and you're still making an okay amount of hormones, but you're definitely starting to notice symptoms. I know you said something about you should get ahead of it, and other people have said that too, get ahead of it and start looking into using hormone replacement. So I would love your thoughts on that too.
Yeah, well, so definitely get with, a functional GYN. I mean, you don't have to start an estrogen patch. That's not even appropriate if you're still getting regular cycles and you are, in your early 40s. Although I really, as I'm saying this, I'm thinking, well, that may not be right because women go through menopause surgically younger, right?
Yeah.
Or, they may just have low estrogen. So work with a doctor. You can certainly do a tiny microdose of estrogen, like some Biest cream. You can obviously do those progesterone troches. So it really depends on what your current testing would look like.
Right.
But yes, women, I believe, get as far ahead as you can, because imagine transitioning through menopause where, your ovarian reserves are declining steadily each month, but you have replenishment. So like your body's just like, oh, thank God I've got support in here.
Right.
It's really nice.
Scaffolding the hormones.
Scaffolding. Beautiful. Yes. I can't think of a better analogy.
Yeah. Just so everyone is aware or is, clear on Biest, can you just describe what that is, just so everyone knows?
Oh, it's oh my gosh. This is where my mind is going blank right now. I know okay. It's a nice combination of very gentle bioidentical estrogens. If you want me to get into better biochemistry, no, I'd have to let me get back and come on a podcast again and I'll give you a full soliloquy.
No, it's all good. I just wanted just a clarification on it because I feel like people listen to this from all different parts of the world. And so I just wanted them to know what that was.
Yes.
I believe, isn't it estradiol and estriol? I think it might
be
the two, right?
Thank you. Yes, thank you.
Yeah, yes. No worries. All good. I just wanted to make sure that, people knew. And, and I also, to come back to that hormone replacement conversation again, about where, oftentimes doctors are just providing the pill or an IUD. why is that happening? Is it, like you said, because the updates have just come in 2022 to how to deal with women in menopause? Or is it because that's just like what's the going thing right now, the pill, the IUD? Like, what is happening? Because I talk to women who are 55 and they're like, yeah, I'm still on the pill. And I'm like, wait, what? What is happening here?
I know.
So that seems crazy to me.
Yeah. And actually, and the first position paper on the North American Menopause Society was done in 2017, 2018, where they were like, oops, that scary study, that Women's Health Initiative that used the urine of pregnant horses to treat menopausal women, and said, and scared everyone and said, oh, it causes cancer, don't use it. The data was completely flubbed. So back in 2017, 2018, NAMS said, oops, that was not a great study. It's okay. And now they've just like continued that. They just updated that. So your question was, why do doctors prescribe the pill and the IUD? Because it stabilizes the symptoms of menopause. It controls the symptoms to a degree.
Yeah.
To a degree. And really, it's too high of a level for women in menopause. Bioidentical hormones are like a fifth of the dose of the birth control pill. It's a microdose. So we don't need to be at the same hormone levels as we were in our 20s and 30s. Our body's not needing that. So it's just enough to, again, maintain bone density, prevent cognitive decline, because estrogen, oh my gosh, the benefits of estrogen on the brain and cognitive function and neuroplasticity are phenomenal. Phenomenal. And, with bone density, you can take all the calcium and vitamin D and vitamin K in the world, but if you're not on estrogen, it's much harder to get the much better outcome with your bones. And also with estrogen, it prevents vaginal atrophy and also pelvic floor and bladder issues, right? Because a lot of women are incontinent as they age. You go into any nursing home, like 2/3 of the women are in diapers, right?
Yeah.
That's low estrogen a lot of the times.
Right.
So, and prolapse and and vaginal dryness. Whereas if you have proper estrogen dosing, and by the way, you can receive vaginal estrogen as well, which is again a microdose. It doesn't even travel into your bloodstream. So even, post-cancer patients can use it quite safely. And obviously check with your oncologist. I'm not your doctor. I'm not responsible for your medical care, for disclaimer here, but it maintains the collagen and thickness of the vaginal walls so that you produce moisture and lubrication. So that's also really important. So the pill and the IUDs don't do that. And they don't, as I said earlier, they don't have the same biochemical benefits in the brain. So they're not going to help your depression, your anxiety, your mood, nothing like that.
Yeah.
So what I help people do, but yes, I mean, I do liaise with people's doctors and say, hey, how do we transition people off the pill and onto bioidentical hormones? And the only downside to that is that some women do go through, again, an adjustment period and re-experience hot flashes when they're shifting their estrogen dose. And they shouldn't go from the pill to like the lowest dose. They should actually be at a relatively higher dose that's still lower than the pill, but higher than the baseline of, a starting point for someone just starting bioidentical hormone replacement.
Okay, that's so helpful. And, coming back to what you were talking about with the dietary side of things, exercise, all of that stuff. I was thinking about just sort of optimizing your health in your 40s. I feel like this is it, ladies. you got to do it now, because really things do shift so much after this. And and you mentioned insulin as well. So I know that when we're losing our hormones, particularly estrogen, it creates more of an insulin resistance type scenario. What do you do in terms of the dietary perspective? Like what shifts should people be making? Just a few things I think that would be helpful for people who are listening.
Number one, do not give up carbohydrates, ladies.
Yes.
Okay.
Okay, let's talk about this.
do not, no keto. No. Keto works great for a lot of women temporarily, It works for the first 3 months you can do it. Number one, ask any woman you know how long she has maintained keto. 3 months is about the time she hits her wall because she cannot look at another stick of butter or avocado. Number two, your adrenals and thyroid tend to start to really shut down at that point. We need carbohydrates to convert T4 to T3, which is the active form of thyroid hormone. And number three, if you take away my carbs, I can tell you, I don't sleep. I don't sleep. So imagine how many other women are struggling to sleep because they are on lower carbs. Now, there are those of you listening that say, lady, you're crazy. I feel great on low carbs. No problem. If that works for you, far be it from me to stop you. But for those of you who are like regular consumers of carbs and then want to all of a sudden cut down to 50 grams a day, that's going to be really harsh and tough. So I do recommend that you track. I love tracking apps. MyFitnessPal is a great free one that you can use, but just track a normal day's eating and see how many grams of carbs you're eating and see how many grams of protein you're eating, right? Let's say you're eating 150 grams of protein. I really like your protein to be at a higher ratio than your carbs. So if you're getting 150 grams of protein, try like 110, 120 grams of carbs, because that is going to give you the satiety and the satisfaction and the blood sugar balance that you will need to not gain weight. But the other thing you want to do is I recommend a nice good cup of carbs, like at least 40 grams of carbs at night for dinner. I'm not so worried about during the day. But at night, I definitely want you to have, a good quality starch, a potato, a sweet potato, some rice, some quinoa, some butternut or acorn or spaghetti squash. Those are beans and lentils. Those are all really high quality carbs that will actually help you get a good night's sleep. And people are like, oh my God, you're having me eat white rice and white potatoes. Yes, because I'm going to help you sleep. And when you sleep, you're going to correct your insulin resistance anyway. So you really have to think about the bigger picture. And by the way, you're going to feel fuller. You're not going to be snacking or waking up with low blood sugar at 3 a.m. and your cortisol jacked, your insulin drops, your cortisol shoots up and ding, like here I am wide awake, not sleeping and maybe starting to hot flash too.
Don't be like me, ladies. Don't be like me. Yep. Okay. So final thing with that, because I think that that's so great. We're talking about dietary dogma, and I wanted to talk about intermittent fasting because that's another one as well that oftentimes I hear amazing things. And in fact, I do it as well periodically. I don't do it like every single day, but I'm curious about it for women in perimenopause. I hear great things. And then I also, on the flip side, you hear other things. So it's, again, right. I think it's just so confusing for women. And then they're just thinking, oh, well, I'll try this because this person told me that this is the key to all of my problems.
That's right. And it's really, really individual. When I wrote Cavewomen Don't Get Fat, I looked at 73 different studies on intermittent fasting and only 13 were done on women. So the research, of course, what a shocker. Shocker, research is mostly done on men. So yes, it's
even to today. I mean, and you wrote that a while back, and even now, I think that it's still less than 40% of studies done, including women, on conditions that actually affect women. It's madness.
It's madness.
Yeah.
So, number one, you may find you do better the first half versus the second half of your cycle. That would be a good time to experiment. Number two, just start with a 12-hour fast. Don't go full blown, 18-hour fast. Start with 12 hours. Just finish your dinner at 7 p.m. and don't eat breakfast until after 7 a.m. That's just a really gentle, still really effective fast. Number two, then you can start to gradually, maybe you have breakfast at 9 or 10 and then dinner at 6. And then you could, increase that if you want from 12 to 6. The other really effective weight loss tool that I use in practice, and again, I don't use it until we've tried lots of other things first, but you can do the 5-2 method where you're eating normally for 5 days and then 2 days out of the week, you eat 500 calories a day. So that also really shocks the system into fat loss. But again, if you have low blood sugar issues, if you're shaky and irritable when you skip meals, if you're just hangry and can't focus and can't think and your cortisol is super low, don't do it. You're better off wearing a continuous glucose monitor and seeing the physiological effects of your meals, of your workouts, of poor night's sleep versus a good night's sleep, or an Oura ring. Use some tracking methods that are going to enable you to biohack your metabolism better.
I'm all about the biohacking, and I'm all about the tracking devices. They're so helpful.
I know. I saw your gorgeous gold Oura ring last night. I was like, they're very pretty. They really are.
They are quite pretty.
Nice designs.
They've come a long way. Yes. Esther, thank you so much. This was, I feel like, super enlightening. And again, it feels like an easy way to approach perimenopause and menopause without all of these crazy feeling restrictions and diets that I constantly see out in the world. Where can everyone find your amazing book? See you later. I'll be later. I'm going to keep saying that.
First, I want you all to go to estherblum.com/cocktail and download my Happy Hormone Cocktail. That's going to really touch on the things that we spoke about today. And then when you do that, you will actually get on the priority notification list for my book release. The book is available on Amazon and will be available in stores, in retail stores, but just get on the priority notification list. So I'll tell you all about it and when to order.
Amazing. And you also offer services to people who just need help, more one-on-one or more specialty help, right?
I absolutely do. Yes, I do.
Amazing. Thank you again so much. And for everyone who's listening, thank you for being here this week. And I will see you on the next episode next week. Thanks, everyone. Thanks, Esther.
Thank you.
That's a wrap. Be sure to click that subscribe button to join me for more Girl Talk Gone Menstrual in upcoming episodes. But in the meantime, check out my latest Period Party episode. And if you're looking for a deeper dive into your hormones, go ahead and take my period quiz at NicoleJardim.com/quiz.